welcome everyone to our webinar Wednesday on blood cancers. So September is Blood Cancer Awareness Month, and so we are just thrilled to have a speaker for that topic today. As a reminder, please mute your microphone when not speaking. This webinar is streamed to Facebook Live and will be uploaded to YouTube later, just as an FYI. For those of you who are joining us on Zoom, please use the chat box to ask questions during the presentation, and then we'll have some time for Q&A after the presentation as well. And for those of you who are joining us on Facebook Live, please use the comments section on the Facebook Live video to ask any questions for our speaker. The Webinar Wednesday series is brought to you by the University of Chicago Comprehensive Cancer Center Office of Community Engagement and Cancer Health Equity. My name is Aaliyah Poulos, and I am an Education Outreach Specialist in this office. I'm joined today by my colleague, Erica Rodriguez, who is our Latinx Outreach Specialist. So for those of you who are on Zoom, if something comes up, you can shoot a message to either Erica or myself, and we can help you. So our office is the community engagement arm of the Cancer Research Center at the University of Chicago, and we serve as a bridge or liaison between the greater Chicago communities and our cancer researchers and cancer clinical faculty. Our speaker today is Dr. Lucy Godley, and I'm going to stop sharing my screen and throw it to Dr. Godley, who will be able to introduce herself and start our presentation today on blood cancers. So Dr. Godley, it's all you.
Thanks so much, Aaliyah, for having me again. Sorry, everybody, and welcome. Thank you for taking the noon hour to join me in thinking about blood cancers and kind of using my lens, so to speak, how I see these diseases and the patients. So let me share my screen. And actually, give me 1 second here to turn off this Outlook, which is just going to be way too loud. Okay, so hopefully you can see my, let me go play from the start. So now you should just see my slides. Now I'm a physician scientist, meaning that I work in the laboratory and do basic science. And then I go into the clinic and I see patients. And I have what I call a molecular lens, not just my glasses, but I see patients with a science lens or bent or perspective. And I think you'll see that as I take you through how I started to think about my patients. Now the title is kind of a sciencey kind of title. Germline predisposition means inherited risk to the blood cancers. And we used to think that inherited risk to cancer only affected solid tumors. But of course, that doesn't make much sense because the bone marrow is the most proliferative, most actively dividing tissue in the body. And so how could it be, if the cells are dividing so much in the bone marrow, how could it be that inherited predisposition only affects the solid tumors where the cells grow much more slowly? So this didn't really make sense. And then I went to the clinic and I started seeing patients, and I talk a lot to my patients about their personal and family histories. And I started feeling like these people are programmed to get their diseases. And so I just want to open by thanking my patients and their families. This is a thank you note that the daughter of one of my patients gave to me, thanking me for caring for her mother. And I really love it because it's supposed to be, she drew me, this is me here, where my arm becomes the bone marrow biopsy needle. And I'm doing a bone marrow biopsy on her mom. And I promise you, she was never in the room at the time I did a bone marrow biopsy on her mom, but she really depicted it quite well. But really, I thank them because without being in the clinic, I would have been in the laboratory studying what I was studying, which really in the end was a bit removed, I think. When I really learned from the patients, then I think we got much more to the kernel of what's driving their diseases. And in the lab, I have a lot of people who are working very, very hard to understand the science behind these diseases. And on the clinical side, I have my colleagues who are very, very cooperative, and they have developed what I think is the world's best testing platform for these kind of diseases. So I think about patients on multiple levels. First, their inherited risk. What DNA are they born with that just a priori gives them a risk to cancer? And then what happens to them over time as they're exposed to different chemicals in our lives or things we breathe to combine and give them a higher risk for cancer. So right now, this is how we find our patients and what we do. And this algorithm that you're looking at, I really think has set the standard throughout the world. And people and other institutions throughout the world look at this outline and they try to match what we have here at University of Chicago. So I'm very, very proud of that. And I think it shows you how here at University of Chicago, we have a very cooperative environment. So people listen to one another and they adjust what they're doing and change what they're doing to, we have this phrase, be at the forefront. And I think really here it's true. This clinical pipeline is at the forefront of this kind of testing throughout the world. So first of all, we pay attention to our families' histories and our patients' histories, their personal history, if they have more than one cancer, and if they have clustering of cancer in their families. And we take that personal and family history every time one of our patients has a bone marrow biopsy. Our patients have blood cancers, and a lot of them get evaluated through a bone marrow biopsy. And in that bone marrow biopsy, we cut into the skin to allow that needle that you saw from my arm to go in and do the procedure. And when we cut into the skin, it allows us to take a little piece of that skin, and we can grow the skin in the laboratory. And the skin actually gives us the inherited DNA. Because our patients have a blood cancer, when we access the bone marrow, we are looking at a bone marrow or blood tissue, and that is affected with their disease. So it's hard to distinguish what was inherited from what was acquired over time. So when we do that skin biopsy, we're looking at the inherited DNA, and we have a clinical laboratory dedicated to growing the skin and isolating the DNA. And then we have another clinical laboratory that has developed, I think, what is the world's best testing platform for these diseases. And they've worked out very careful analyses that allow us to detect all kinds of mutations, many of which are not detectable by most commercial testing platforms. That's why our test is considered the best in the world. Now, our pathology department has developed another testing platform that's specifically designed to look for the acquired mutations that we see as those cancers develop. And we take that information and try to look at it and tease with our lens, find which are the people who might actually have that DNA mutation as an inherited mutation. And then lastly, we do a lot of stem cell transplants for patients with blood cancers. And if there's a family mutation, we don't want to use a donor that shares that mutation or an unrelated donor who might have an inherited mutation. So we pay a lot of attention to this phenomenon at the time of using relatives to do a stem cell transplant. So from all these different ways, we find these patients and we do this testing. When it's positive, we do cascade testing throughout the family. And when I say family, I don't just mean the immediate family that comes with the patient. I mean their extended family all over the world. We've done testing as far away as Jordan and Israel, all across the world to find the relatives of our patients. And if someone tests negative for what we know of today, then they go into our research pile. And the research is really important. We discover new syndromes and we describe them through publication. And then they're out there in the world. And I can tell you just last night, I was emailing with doctors in Seattle who have a patient with an inherited mutation that's exactly the same mutation as what we first described about a year ago. And from that one publication, I already have heard of two patients, one in Boston and one in Seattle, who have that exact same mutation. So clearly, this is not as rare as what everybody is saying. If within a year of publication, we already have two unrelated patients in the United States identified with that syndrome. So this is why it's so important to do the research, and that feeds back into the clinical testing. So right now, what we look for here, these are the criteria to do that clinical testing. First of all, patients with multiple cancers. We've talked about therapy-related leukemias for many years, especially here at University of Chicago. These are leukemias that arise after treatment for a solid tumor, say a breast cancer patient who now develops a leukemia, or someone with an autoimmune disease who might have been treated with chemotherapy, who now comes down with a leukemia. We actually have more patients who first had a solid tumor, first had a blood cancer and survived that, and then developed a solid tumor, that we realize it doesn't matter the order in which you get the solid tumor or the blood cancer. In either case, the positive testing rate is about 20%. So we pay a lot of attention to that personal history. We also pay attention to people who have a blood cancer diagnosed at a much earlier age compared to the average. So the example here might be myelodysplastic syndrome, which the average age of diagnosis is in the late 60s or early 70s. So why is a 25-year-old person getting myelodysplastic syndrome? We now know that a very high percentage of young people with an older person's disease actually have that disease because they had inherited risk. But this doesn't mean that if you have myelodysplastic syndrome diagnosed at 70, that the inherited risk is not contributing. And I think that's something that people have assumed, that a 70-year-old doesn't have any inherited risk, that a 70-year-old is getting cancer just because of everything they've experienced in their life. That, I think, we're really breaking down that misconception. And so here at University of Chicago, we consider inherited risk throughout the entire age range of life. We pay attention to that family history, and we consider a positive family history for a patient with a blood cancer to be the diagnosis of another blood cancer within 2 generations, or an individual with a solid tumor diagnosed at 50 years or younger in 2 generations from that individual. We also ask about other blood abnormalities like anemias or funny sizes of cells, but this is much harder for people to know about compared to the cancer history in the family. So what happens when we take those criteria and test our patients? Well, you can see we test across the entire age range of life, and the testing rate is about positive 20%, 1 out of every 5 people. This is too high, actually. From a human genetic standpoint, we want a positive testing rate of about 5 to 10%. So this means our criteria are not even broad enough. We should be testing even more people. And a lot of people challenge me to say, why aren't we just testing everybody? And you can challenge me that, or I'll answer the question now. Why we aren't testing everyone? Number one, we don't have the data to justify it so that insurance companies will pay for it. We don't want our patients saddled with large bills, and we have to develop the data. And once we have the data, then things become standard of care, then insurance companies pay for them. So that's where we have to, again, go into research and show people that this is more common than what I was certainly taught in my fellowship. So this is that paradigm that I'm giving you for consideration. We do research, we identify new syndromes. We've contributed to the definition of inherited DDX41, which is now recognized to be the most common inherited predisposition syndrome, inherited ETV6 mutations, and inherited CSF3R. And this is the one I was discussing with those doctors in Seattle last night. Once we identify these and publish them, now they're considered clinically actionable. They're real, so to speak. And that means clinical laboratories across the country and across the world will start including them on their testing platforms. We can learn more about established inherited syndromes like the BRCA, or you might call it the BRCA genes, BRCA1 and 2, and this one that we're very interested in, CHEK2. Hopefully we'll have a few minutes to talk about CHEK2. And then these, which we've known clinically for a long time, they drive our research to understand exactly how these genes are misfunctioning in the bone marrow to give us those cancers. So this is the link between the clinical testing and the research. One feeds off the other, and they deepen the interpretation that we can use one for the other. So I try to show people that this is a common phenomenon, and this is one way I do it, by putting it in tables. And another way I'm doing it now is through this riddle that we have that goes, how much does a ton of feathers weigh? And of course, it's a riddle or kind of a paradox because each feather is very light. But if you have enough of them, you have something very heavy. And likewise, each one of these disorders or syndromes might be considered relatively rare, but there are so many of them that this is a common phenomenon overall. And I make some of these feathers kind of big here at the bottom, because this one, bone marrow failure syndromes or dyskeratosis congenita, by itself is already comprised of many, many, many genes. So we could ask ourselves, how many more are there? I think there are lots more, actually. We're working on another probably 3 right now in the laboratory. Hopefully they'll get published in the next year. And, you know, I'm not even sure I can guess how many there really are. We can see in a few more years how many more we've been able to find. So now let's take a moment and think about the lens of the clinical testing that's being done on leukemia cells or other bone marrow cancers. And when we see a DNA mutation in those tumor cells, how do we know that they're just in the tumor cells and part of the tumor itself? How do we know that they aren't in all the cells of the body actually as an inherited mutation? And this is, I'm going to skip over these because these slides are a little bit technical. I don't think they're as important for this audience. But we had that question. So if you run this testing platform that's designed to help you prognosticate or say if something is aggressive or something is going to be an indolent tumor, sometimes those DNA mutations might actually be inherited. And how often does that happen? And it turns out that it happens pretty commonly. So we did that, and 25% of these variants that were within range of being inherited were actually inherited mutation. That means we can use the platform that's being done on the tumor tissue as a way of finding these individuals and families. And so every month I get a list from pathology of every variant called in every gene associated with inherited risk. And I look with my lens and I try to see which one of these individuals is at high risk for having this DNA mutation as an inherited mutation. And what I do if I think the individual's at high risk, I talk to the clinic doctor and I say, hey, your patient so-and-so might have that DNA change actually as an inherited change. And that's important information for the individual, patient, and for the family. And usually my colleagues will say, oh, that's really important. Let's go ahead and prioritize that person for a skin biopsy the next time we're going to do a bone marrow biopsy, or we'll just ask you to do a skin biopsy the next time that person comes in. So we try to use all the data we can, all the data we have on people to find these individuals and these families. And this is what it looks like when we plot those numbers over time. So a DNA mutation that is called somatic or only present in the cancer, it goes away when the cancer goes into remission. But if the DNA mutation is inherited, it's in all that person's cells, whether there's tumor or not. And so that number stays high. And we actually use this kind of plotting of these numbers over time, and we calculate how much that number is changing to find these individuals. I'll just give you an example here from my clinic. One of my patients was diagnosed with acute myeloid leukemia when he was 78 years old. So he was not young for the diagnosis, and his family history was not putting him at high risk. So he had a mother with breast cancer diagnosed over 50, and he had 2 uncles who had lung cancer and they were smokers. So he was not prioritized for inherited risk. But when we did that molecular profiling of his leukemia, we see one mutation that disappeared basically when he went into clinical remission, but another mutation that stayed at a very high level. And so this discord, this unevenness between the change tells us that this one was here to stay. This TP53 variant was in what we call in the germline. This is inherited. And this individual has kind of a famous syndrome called Li-Fraumeni syndrome. It was the first inherited tumor syndrome identified. You would never have guessed that from this family history. This person and his family, they don't fulfill any of the clinical criteria that have been defined for that syndrome. And that's what we see again and again and again, because these syndromes were defined ascertaining on patients with solid tumors. And so what this looks like when you start with somebody with a blood cancer, it starts to look really different. So we miss these people unless we have this kind of molecular analysis. And so this is why we work very closely with our pathologists. And this is why we're able to make these diagnoses that weren't able to be found in any other way. This is what it looks like when we plot these numbers over time. And now you can all look at this and say, hey, wait a minute, here's some straight lines around 50%. And these two people also have that Li-Fraumeni syndrome. And they also would never have fulfilled any criteria that have been defined for that syndrome. This is what the BRCAs look like, or BRCA1 and 2. They're usually inherited. They are not usually acquired just in the blood cancers. And so you can see how just plotting these over time, they really help you figure out if that is an inherited disorder or not. And so for most of the time, when we see a variance in most genes, we can't tell just by looking at it, whether it's inherited, what we call germline, or whether it's just in the tumor, what we call somatic. There are a few, though, that we can look just at that change, and we can pretty much know that it's an inherited mutation. And those are for the genes CHEK2 and that DDX41. The DDX41 is one that we helped discover here, and the CHEK2 is one that we're sort of rediscovering with our population here at University of Chicago. That DDX41 has become kind of famous since we first described it, and all over the world now, many, many inherited mutations have been identified. And we have an undergrad right now who's putting together our University of Chicago families with DDX41. We have about 50 families with the DDX41 mutations, and that's the largest cohort in the world. And so what she's putting together, describing what we see in those 50 families, is going to continue to inform the world about this syndrome. Now, we've used this analysis of just plotting and finding the genes that give us these straight lines to discover a new syndrome, that CSF3R. And this is the paper that I was first talking to you about. We published this about a year ago, and now doctors across the country and hopefully across the world are looking for this in their patients. And then they contact us and ask us for our experience and try to do the right thing by their patient. And so in this case, the patient in Seattle who has this mutation, they're about ready to do a sibling transplant. And they looked, and the sibling donor also has this inherited mutation. And so now the doctors are hesitating. Do we use this related donor or not? Are these stem cells really going to function normally or not? And that's what we were kind of discussing. We don't have all the answers, which makes it difficult to talk with patients and families. But as I said to them, I do think patients and families are comfortable with the fact that doctors don't know everything. And as long as we're straightforward with what we know, what we don't know, what might be true, what might happen, what we think could happen, it helps us have informed conversations with people. And I think people are absolutely comfortable with us not knowing everything and just being as direct as we can. Where does our knowledge end? Where does our speculation begin? And how can we work together to weigh the options and have patients and families choose the best option for themselves? So I just want to share with you some data that we're just having published in the last few months from, again, from our patients here at University of Chicago. This idea that myelodysplastic syndrome, a disease of elderly people, it can occur rarely in the young. Why are these young people getting the myelodysplastic syndrome? And so we took samples from patients actually from all over the world. These are our colleagues from all over the world to collect these about 120 samples from people diagnosed with myelodysplastic syndrome in the adult age range from 18 to 40 years old. And the answer is, if you present as a young person, regardless of the family history, just the diagnosis in a young person, you have a very high chance of having an inherited mutation. about 20% if you were diagnosed with myelodysplastic syndrome, and about 15% if you were diagnosed with aplastic anemia. Now, this study took us about 5 years because it took us a long time to collect all these samples. And some of these samples were very old. Some of the samples were 20 years old that we used. And unbeknownst to us, the pediatricians across the world had the same question, and they were doing the same experiment. And so if you put our data together with what the pediatricians were doing, what you see is that the age at which someone presents with myelodysplastic syndrome just reads out for you the DNA mutation. So if you have MDS as a young child, say from birth to 5 years old, you probably have an inherited mutation in one of these 2 genes. If you present as a teenager, you probably have an inherited GATA2 mutation. And if you present as a young adult, you probably have a mutation in a gene important in DNA repair or telomeres, the ends of the chromosomes. And if you present in a normal age range for MDS, in that elderly age range, you probably have DDX41. And now we have an age gap, right? Wouldn't you like to know from 41 to 80 what the answer is? And we're starting to fill that gap. And the answer is yes, there are inherited DNA mutations at every single age. And probably when we publish that answer, we will change the way MDS is diagnosed, and we will argue for inherited testing on every MDS patient, regardless of age. So this is how our research is going to change clinical medicine in the coming years. Now, we'd also like to know if you are born with an inherited mutation, what happens to you over time to get you to have malignancy? Because if we understood that natural history, then we could block it. And I just want to share with you some ideas. First of all, it turns out DNA repair is really important, right? Because your bone marrow is constantly making new cells. And when new cells are made, there are mistakes in the DNA and you need to fix them. But if you have a problem in DNA repair pathway, you don't fix them very well. And so you have mistakes in your stem cells, or you try to correct with backup pathways that are very error prone, and you make more mistakes. And this is how people are sort of set in place for getting a blood cancer. Now, we talked about CHEK2 a little bit. I'm just going to spend a few minutes on CHEK2. Here in Chicago, we have a lot of Polish people. And that means we have a lot of DNA mutations that come from the Polish population. CHEK2 is one of those. And so we have lots of CHEK2 mutation families, about 50 again. Half of them have exactly the same mutation. It's called I200T. The next most common one is an Ashkenazi Jewish mutation called the S428F. Now, you might say that we see a lot of people with this mutation because they're somewhat common in the population, but we've done calculations about that. We actually see more people than we should from the general population. It's kind of like when we find them with leukemia, we're selecting for people with these mutations. So we decided we needed to take more look at this. And before I show you our data, I'm just going to share with you data that came out within the past year, showing that if you look in the general population, just people out walking on the street, who's at risk for developing leukemia? It's people walking around with CHEK2 mutations. And which mutation? Exactly the one we see. So we may have CHEK2 focused glasses, but this study was completely agnostic to knowing what gene mutations are out there giving risk. They came up with the same thing that we did. So we found our patients have lots of CHEK2 I200T mutations. Let's test this. Let's make a mouse that looks like the people, if you will. So we engineered the mouse to have that mutation. It's a little bit different in the mouse. It's called I161T. And lo and behold, what happens to that mouse? It also develops risk for leukemia. And with even more time, it develops leukemias and lymphomas, just like our patients. So now we have a model and we can start to ask what makes this worse and what makes this better. And that will hopefully help our patients. We've been doing this with BRCA1. you think of BRCA1, or you may pronounce it BRCA1, as a breast ovarian cancer gene. That's what's out in the lay public. But actually, BRCA1 and 2 are really important in the bone marrow. They're what are called Fanconi anemia-like genes. And we were the first group to show this by knocking out or deleting this gene from the mouse bone marrow specifically. And that mouse also gets leukemias. So we're using these mice again to understand what our patients are at risk for and try to do better for our patients. And I'm just going to end on this idea. And we don't have to go into the details of this idea, but we use another mouse to show that the way this mouse gets cancer is because bacteria from the gut of the mouse, from the inside the intestines, sneaks its way into the blood. And when those bacteria get into the blood, it causes inflammation in the mouse, and that inflammation is what's driving the cancer. So this idea that there's systemic inflammation driving cancer is becoming more and more accepted, I would say. And we'd really like to know if this is happening in our patients. So those CHEK2 patients who are out there who are at risk, those BRCA1 and 2 mutated patients who are out there, if they have something stimulating inflammation in their bodies, is that what's driving them to get the cancer, the blood cancer, or maybe even the solid tumor? And if that's true, can we disrupt it? So these are some of the ideas that we have. Again, some of these ideas we take from the clinic, make the mouse, then test the mouse, and then reflect back into the clinic. So again, that's that paradigm. You know, does this phenomenon happen in people? Can we measure it? What are the sources of inflammation? And can we block it? So that's where I kind of would like to end. Just again, saying that we're all born with inherited risk. What's important to me is just open our eyes, recognize what each of our risks is, and then understand the risks we have throughout our lives in terms of what we're exposed to as doctors, minimize our therapies so that we allow our patients to survive a first cancer, but don't give them even more risk for a second, third, fourth, and fifth cancer. And I really think understanding all of this together is within my professional lifetime. I think very soon we'll be doing this on a very standard basis. And I hope it improves the lives of our patients. I hope this information isn't scary to people, but rather people take this information and use it in a proactive way to make their lives better. And with that, I'm going to stop, and I'm very happy to take your questions.
Thank you so much for all that information, Dr. Godley. So I have some questions here that have come into me through the chat that I've been writing down. Well, first, I actually wanted to ask, could you just briefly go over what are the types of blood cancers that there are? Is it just leukemia and lymphoma? Are there other types of blood cancers that we need to be vigilant about or looking out for?
I mean, a little bit depends on your definitions, and the pathologists are always slicing and dicing these diseases. So very broadly, yes, we call them leukemias and lymphomas. Now, some people will say, what about multiple myeloma? I consider that almost a lymphoma because it comes from B cells. So again, it a little bit depends how you slice and dice things, but any cancer that arises from the blood or bone marrow system, which comes from myeloid cells or lymphoid cells, these are considered the blood cancers. If I were to give you the list of the diagnostic list, it's probably between 100 and 200 different diagnoses.
Oh, wow. Is there a, for a patient, is there a notable difference between being diagnosed with leukemia versus lymphoma?
It's a great question. Actually, when I was a fellow, a first-year fellow starting out, I came to Dr. Larson, who was my attending, and I said, Dr. Larson, this local doctor is very confused. He says the patient has leukemia and lymphoma at the same time. And of course, it turns out it's the same disease. It just goes by two different names. And I didn't know that yet. We call something a leukemia when the tumor cells are floating in the blood. And we call something a lymphoma, these are generally speaking, when those cells are more solid in the lymph nodes or in the organs. Again, these are generalizations. You can have a leukemia present as a solid tumor. We call it a myeloid sarcoma. But in general, in the broadest of strokes, leukemias are when the cells float in the blood, and lymphomas are when the cells are sort of, in one lymph node area or growing as more of a solid mass.
And are blood cancer staged like other cancers, like stage 1 through 4?
The lymphomas are often staged in that sort of way. Leukemia, I like to say it's more like being pregnant. You are or you aren't. You either have detectable leukemia or you don't. And there's a question about measurable residual disease, or some people say minimal residual disease. This idea that we can track cancer very easily. You can see all these molecular tests that we have now. We have many, many different ways of finding these blood cancers. First of all, they're blood cancers, so you can look in the blood, or bone marrow biopsies are very easy to do. Our cells are very accessible. It's not like a pancreatic cancer that's very deep in the body and hard to get to. Our tumors are easy to get to. That's why the science comes to our cancers first, because it's so easy to get purified tumor cells. So we can use very sophisticated tests to look for very small numbers of our tumor cells. And so this is called measurable residual disease. Like, by the most sensitive test, can you find that tumor cell? And if you can, we say somebody has measurable disease. If we can't, we call them in remission. And we hope that our patients are in remission, that they're actually cured. But we tend not to use that word cure because we're so nervous that our tests are only so good. And it could be one or two sneaky little cells there, could be there in the person's body. And that's why it's difficult for our patients to take that black cloud of relapse away from them. It goes further and further into the back of their lives, but it never completely goes away, because we never really, we almost never use that word cure.
I have a question here that was sent to me. It said, is the inflammation that you spoke of from diet?
It's a great question. A great question. Probably. And the reason I say that, let me just say many sources of inflammation. First of all, I completely believe in the mind-body connection, right? The idea that anxiety plays a role. So why is meditation important? Why is exercise important? Why is yoga important? This is the mind-body connection. And it's not, the real biology there is the inflammation. So meditation, yoga, exercise, it all brings down the inflammation. Diet, extremely important, because you rely on what you eat, but so do all the organisms living in your gut. And so depending on what you eat, you change what's living there or what those microorganisms are making. And they make chemicals and substances that your body then absorbs. So those mice I was talking about, that we can change, we can actually turn the tumor on or off depending on whether there are gut microbes in the mice or not. We can do the same thing with what the mice eat. So shouldn't we all really think about what is in my gut? How can I have a healthy microbiome, we call it? What do I eat so that my microbiome produces good substances, not bad substances? These are really important questions, and we don't have all the answers yet. We're just starting to appreciate how the diet affects the hormones that our bodies produce, especially the female body, and how what we eat affects that microbiome, and how that in turn affects our risk for cancer. So everything is tied together.
So is it possible, I know that you work mostly in genetics, is it possible to get a blood cancer without a gene mutation?
Absolutely, yes. There's lots of risk out there. We don't understand it all. I would say in my clinical practice, where I can identify risk other than, one risk is inherited risk. Another area of risk that we definitely see is people exposed to large doses of radiation. Now, you would think that we don't have that anymore, that we got, thank goodness we haven't had atomic bomb explosions and things like that, but we have. So here in Chicago, we have a lot of Chernobyl radiation survivors who've emigrated from that area of the world into Chicago, and they have a lot of cancers. And people are exposed in their jobs sometimes to high levels of radiation. So that's one risk. And then we see another risk, people exposed to chemicals like benzene have a risk for blood cancers. So there are lots of risks. And some can be avoided and some can't.
Someone asked a question here: if a newborn is presented with a leukemia or lymphoma or any other kind of blood cancer, is it almost always inherited?
I would not say that. I would say it depends on the type of leukemia or lymphoma. So if a newborn is presenting with myelodysplastic syndrome, that cancer that's usually diagnosed in the elderly, yes, it's probably inherited. But if that newborn presents with acute lymphoblastic leukemia, it may not be inherited. It may be, but it doesn't necessarily. Again, this gets at the question of, we screen newborns for lots of rare metabolic diseases like phenylketonuria, for example. Why aren't we screening them for inherited risk? That is something that we don't do right now, but maybe we will within my professional lifetime. I do think, I'm an adult oncologist. I do think in my professional lifetime, very soon, we will be doing very standardized screening for inherited risk in our adults. When that will come down to the kids, I mean, it may happen within the few years. We need the data. So we need to understand whether it's justified. Now, people in peds will say, for example, why do you need to know so soon? Now, the reason we screen for phenylketonuria, for example, is because what the babies eat has a tremendous impact on that disease. So you need to know right away. But if this risk is giving risk to cancer in the 20s, 30s, 40s, 50s, do you really need to know that at day 2? So these are the kind of questions that the pediatricians weigh in terms of deciding when is appropriate to do the testing.
And are there signs or symptoms of a blood cancer that people should be looking out for or aware of?
Yeah, most of the time, these diseases that we're talking about are not subtle. They are obvious. People do not feel good. And probably the most common thing that people feel is severe fatigue. They just don't feel like themselves. And so when people don't feel good, they should go to their doctor and say, I just don't have the energy that I used to. Now, maybe it's something simple, like their thyroid isn't working. So that's why it's really important to go to your primary doctor, have a regular checkup, and have the right screening tests for what the symptom is. It's also really important to have the general screening that the American Cancer Society recommends, colonoscopies for colon cancers and mammograms for breast cancer and things like that. And again, the primary doctors are the ones who are the gatekeepers for all that testing and can make sure that everybody's on track for their screening.
And is there a screening for blood cancer? Let's say you go to your doctor, you get your thyroid tested and everything else, and everything else looks fine. You don't necessarily have a known genetic risk. Is there a screening specifically for blood cancer then?
Yeah. So if you go to your doctor and say, I'm really, really tired, the doctor's probably going to draw your blood counts, because if you're anemic, you're going to feel really tired. Now, if you're anemic, it doesn't mean you have a blood cancer. You might be a young woman who's menstruating really heavy and just losing too much blood. So there are lots and lots of different reasons why people can have an abnormality on their blood count. And that's why the primary doctors are so good at figuring it out. But generally the screening comes from the blood. It's pretty easy to do. Now, sometimes patients feel like their neck is getting thicker, like, their lymph nodes are growing. They're like, hey, doc, this thing is growing here. That's more characteristic of like a lymphoma. Could be an infection as well. And then usually you need a biopsy of that, of that area.
And then, so if someone finds out that a family member has blood cancer, what do you recommend? Like, what's the first step they should take? First thing they should do?
Yeah. So a lot of times we get these cases, and I have to say, in terms of inherited risk, remember that most doctors were not taught about this. So when I came through my training, I was taught that these families were so rare that if I saw one of them my whole career, I was lucky. And I think we see them every day. I mean, I think that training was so completely wrong. But the problem is doctors have been told this for generations. And so it's hard for people to change what they were taught. And so what I see is the families pay attention to their personal and family histories, and they push the doctors. And they say, look at my family tree. I mean, there is something in my DNA. Like, they get it. And they're saying to the doctors, there's something here. Like a patient who was seen in New York at a very famous center, he had acute myeloid leukemia. His father had acute myeloid leukemia. His father's brother had acute myeloid leukemia. He had 4 uncles with AML. His grandfather had AML. And he said and they actually said to him, yeah, there's got to be something in your DNA. And finally, he connected with me, and I said, yeah, it's probably DDX41. And he said, you mean I've been going to that medical center for 13 years, and they've been telling me that it's inherited for 13 years, but they couldn't tell me what it is, and I can talk to you for 3 minutes, and you can tell me the gene? And I said, yeah, that's the difference, like, because we're used to hearing it, This man had looked at his personal and family history for more than a decade, knowing that there had to be something in the DNA. I've had people draw out their family tree and put a plus by the people they know must have the gene based on the history. They just don't know what the gene is. So a lot of times it's the families, the people who know their personal and family history and know this is not by chance, right? And they just need to keep pushing the doctors and find the doctors who have access to the testing and the understanding to get the proper workup. But again and again and again, I have to say, it's the patients who know what's going on.
We talked to a lot of triple negative breast cancer patients. So if someone has a BRCA mutation, is there a step that they should take to make sure, an additional testing regarding blood cancer, or should they just kind of be hypervigilant for signs and symptoms?
And this is really a scary question, right, Aaliyah? Because we've been we keep increasing the surveillance that these people and these families have to have, right? And so for my DDX41 mutated families, I tell them to have a baseline bone marrow biopsy, to have potentially annual bone marrow biopsies, regular blood counts, and colonoscopies, and breast MRIs, and urine cystoscopies, and dermatology review. Wow. And that's kind of what's happening to a lot of these syndromes. As we realize how broad they are, the screening, it's kind of intense. So for a BRCA1 mutation carrier, I would recommend a baseline bone marrow biopsy. Now, if their blood counts are completely normal, maybe we can just watch the blood counts really closely. And also I'd pay attention to the family history. So we have a family that I'm working with right now that has a BRCA2 mutation coming from the father's side of the family. But now there's a question about whether there's a DDX41 mutation coming from the mother's side of the family. And we've seen multiple risks coming from different sides of the family, many times actually. So we do need to always pay attention to both sides of the family and think about that risk.
I have a question that was sent to me directly. It said, why do they think inflammation causes the cells to grow uncontrollably?
Yeah, it's a really good question. It has to do with what we call inflammatory cytokines. It has to do with the way those inflammatory chemicals activate the growth of the cancer cells. And that's an area of very active research now. There is another question on the chat that says, are there less obvious symptoms besides fatigue? There are lots and lots of symptoms. Chronic itching all over the body. Yes, chronic itching can be a sign of blood cancer. Some people with certain diseases have that kind of itching after hot showers or after alcohol intake. So these kind of odd reactions, again, discuss them with the primary doctor. And if you're not satisfied with the answer you're getting from the primary doctor, go get a second opinion.
So those are all the questions that I see in the chat here and that were sent to me directly. I'm going to do one more quick check on our Facebook Live just to make sure that we don't have any questions coming in there. And I would let our Zoom participants know that if you have another question for Dr. Godley, you can either unmute yourself and ask or drop it in the chat.
Yeah, and I'll just say that if you think about this later, you know, you can always drop me an email or give me a call on the phone. Everything, all those numbers and emails should be on the web. And certainly Aaliyah can get me a question that you would have. So this may not occur to you right now, but it might occur to you later. Oh, the presentation. Yeah, I can definitely give you the slides. I can give them to Aaliyah. They're too big for email, but I can put them on Box. Aaliyah, and you can share them with everybody. Mm-hmm.
Sounds great. All right, thank you so much again, Dr. Godley, for joining us today and providing all this wonderful information about blood cancers. It's been very informative, and we really appreciate you taking time out of your day today.
No problem. Thanks, everybody. Take care.
Thanks, Dr. Godley.